When we talk about metastatic castrate-resistant prostate cancer, there's been a tremendous emphasis in using bone-targeted therapies, not only to treat the cancer in the bone, but also to be bone protective. We all know that prostate cancer's primary site of metastasis is the bone, and that can cause a lot of side effects. There can be fractures, vertebral fractures, spinal cord compression, pain, ambulatory issues associated with pathologic fractures associated with metastatic cancer. So all of the guidelines, the AUA guidelines, NCCN guidelines, and ASCO guidelines have all really put a lot of attention into looking at things such as zoledronic acid or denosumab as ways to either protect the bone or to reinforce the bone in the setting of metastatic disease. So it really has been shown for both of the agents that are out there, the anti-resorptive agents, that they can decrease skeletal-related events in large prospective randomized clinical trials. And in fact, you will see in the guidelines, they get among the highest levels of evidence, and that they're strongly encouraged to be used in the setting of metastatic disease. And many of these agents are also used for standard androgen deprivation therapy in order to minimize bone loss and osteoporosis in patients who are on androgen deprivation therapy.
In a randomized trial, denosumab was compared to zoledronic acid, and it was found that denosumab had a longer time to first skeletal-related event compared to zoledronic acid. And of course, with these agents, you have to look out for certain types of complications, particularly osteonecrosis of the jaw. So the patient should have some sort of dental evaluation before they go on treatment. You have to avoid extractions or anything else that would manipulate the bone of the jaw, which can predispose patients to osteonecrosis. There are specific bone-targeted therapies, as well as some of the treatments that we use also have an effect on bone. So specific bone-targeted therapies include anti-resorptive agents such as bisphosphonates and denosumab, and then the radionuclides, particularly radium-223. Radium-223 is a unique compound. It's an alpha emitter. Alpha emitters deliver high levels of energy to very, very small fields, thus sparing the bone marrow and affording cytotoxicity against the prostate cancer cells. It's unique from the standpoint that the beta emitters, such as strontium and samarium, do not engender a survival benefit. Alpha particles, such as radium-223, do. And in fact, the ASIMCA trial evaluated those patients who were either pre or post docetaxel and found that there was a survival benefit for both groups of those patients. So I like looking at this particular bone-targeted agent as a survival agent rather than a purely palliative agent such as samarium or strontium.